So we are going to go ahead and get started with the afternoon presentations, beginning with Dr. Sabrina Sanchez. She received her doctor's in pharmacy from the University of Illinois at Chicago, and she currently works as an abdominal transplant pharmacist at Loyola University Medical Center. So welcome, Dr. Sanchez.
Great, thanks for having me. Can you guys all hear me?
Yes.
Great. I am a new Zoom user, so I'm going to try to share my slides. We'll see how this goes. So today I wanted to talk to everybody about life on anti-rejection medications after organ transplant. Go on to the next slide. So I don't want to get too technical today, but essentially what happens is that our bodies are wired to defend themselves against foreign invaders. And so after a patient undergoes organ transplant, the body responds to this new organ as if it were a foreign object or foreign invader. And the immune system essentially tries to go into overdrive to try to reject it. This is why it's so vital for our transplant patients to take their anti-rejection medications or immunosuppressant drugs immediately following the organ transplant and for the remainder of their lives. When we think about the transplanted organ, we refer to it as an allograft. Allo meaning it's something different that came from someone else, and graft meaning that it's a piece of living tissue. So sometimes you might hear your team call your organ your allograft. And then in terms of the components that lead to rejection, we're usually thinking about two types of responses: a cellular response, which is mediated by T cells within our body, and then there's a humoral response, which is mediated by the B cells in our body. And again, this interplay of factors can lead to damage to the allograft if we're not trying to prevent it immediately after the transplantation. Next slide. Next slide. Thank you. And again, this next slide is going to be a little bit complicated as well, but just to show you that there's this constant interplay of factors that's pretty much always going on within our body. And this kind of just shows where we're targeting our agents to prevent this long-term damage to our new organ. And so you can slide through this as well. So the next thing we need to talk about is finding that right regimen. So everyone is going to have a little bit of a different risk and a need, right? Everyone's a little bit different. But when we are thinking about the right regimen, there's a couple of things to consider. So you want to consider what is the risk of rejection with that specific organ. So you can see I have a bunch of organs down at the bottom of the slide. And typically we think of our kidney organs, which are over on the right-hand side next to that liver, as being a little bit more immunogenic, meaning that they need perhaps a higher amount of immunosuppression than like a liver transplant, but maybe not as much as someone who gets an intestinal transplant, for example. So that's one consideration to make. Another thing to consider is the transplant timeline. So for example, we think that essentially the most time to be the most aggressive with their immunosuppression is right after the organ transplant itself. We think that that risk is higher right at the beginning, but certainly that risk always exists. So that's the reason why we have to take the anti-rejection medication for the remainder of life. Other things to consider is ethnicity. So some patients, depending on their ethnicity, can be rapid metabolizers of our medication. And so it might be difficult to keep them, for them to maintain a steady level of the medication. So for example, some Asians and African Americans, for example, might require higher doses of their medications than perhaps a Hispanic patient. But that certainly can vary because it's more genetic based, and there's a lot of interplay of factors there as well. And then we also have to consider each patient's prior sensitization. So did this patient have a previous transplant? Were they a patient that required a lot of blood transfusions, or did they have multiple pregnancies? That's important because that could be a method in which our patients develop pre-existing antibodies at the time of transplant, and helps us figure out just how easy or hard it could be to find them a good match. Another thing to consider is the center you're going to be transplanted at and their protocols. yes, there's a lot of dynamics that go into finding the right regimen for each specific patient, but some centers have protocols that they're very comfortable with. And so you might find a little bit of a different practice depending on where you go. But I would say for the most part, most centers are practicing very similarly, and we can talk about that in a bit as well. And then obviously we want to consider each individual patient and their needs. So for example, if we have a patient who's had a high infectious burden, then we want to make sure we're not giving them too much immunosuppression that could cause another infection or put them at risk for more infections, something like that. Okay, next slide. So again, the overarching goal of our immunosuppression is to find that perfect balance for each patient that will bring them the right amount of immune suppression that prevents that allograft rejection. But at the same time, we don't want to give them too much that would lead to a potential toxicity or side effect, such as an infection or something like that. Okay, and we always want to keep doing this, thinking about improving the quality of life of our patients. Next slide. So when I think about the phases of immunosuppression or how we give it, I think about it in certain steps. So there's like essentially 4 steps. So desensitization is something that typically doesn't happen because we're able to utilize all these programs to find a good match. But this is something you would use if it's a very difficult matching process. But I would say that this is not used a ton. Induction, this is going to be our very potent induction immunosuppression that's given at the time of surgery and typically is over by the time you leave the hospital after your organ transplant. And that provides the bridge to the maintenance phase. So the maintenance is going to be that lifelong immunosuppression that you would take on a daily basis at home. And then certainly the intent of maintenance is to avoid rejection. But if there is rejection, then that would be a different phase of immunosuppression where we're introducing more intense medication to try to resolve whatever rejection is noted for that graft. And again, as I mentioned before, this is a lifelong process that will occur after the transplant with the intention of preventing rejection and always keeping in mind that we want to make sure we have that good balance for our patients. Next slide. I think it just kind of talks about everything I sort of talked about before. And so actually, if you could go back real quick to that last figure. At the bottom here, you'll see that I've included 3 boxes with the typical regimen that you'll see at most centers. So most centers do either a 2 or a 3 drug regimen for the maintenance phase. So this is going to be the daily medication that you would take following organ transplant every single day. I would say this is the mainstay of therapy. So most centers are going to do at least part 1 and 2, so your calcineurin inhibitor and an anti-metabolite medication of some sort. And then there are certain centers that like to keep low dose corticosteroids like prednisone on, depending on each patient's individual risk. And then there are certain centers that like to avoid them. So again, that's a very patient-specific type of discussion that you'll be having with your team. We can go to the next slide. So in terms of the induction immunosuppression, so this is again the intense immunosuppression that's given in the perioperative period. It's meant to be very acute, meaning that it only lasts during the part of when you're in the hospital. And it's very potent. So these are very, very strong medications, and sometimes we will see side effects from these medications more than just the day that they're given. And it helps us to kind of downplay that immune response so that we can induce allograft acceptance without having an immediate rejection. And again, the point of this is that we introduce the strong medication so that we can kind of build up and introduce our maintenance medications that our patients would go home on long term. I've just included some of the names of the medications you might see here, but we're not going to go into the specifics of that today. So I'll let you go on to the next slide. So some side effects of these medications, again, these are going to be given in the hospital. So for the most part, if you're experiencing any side effects from the administration of the medications, you're going to have continual evaluation of these side effects by your team while you're hospitalized. So with some patients, depending on what type of induction medication they receive, and if they've had previous I guess, exposure to horses or rabbits, it could cause an antibody response like an infusion reaction or like a rash or something like that. And that's just because the medications, how we make them or how they're derived is from horse and antibody products. And so sometimes I've had a patient who had like a pet bunny growing up and they get this medication and then they develop kind of like an allergic reaction. And so we can definitely manage that while the patient is hospitalized. Again, most of these things are very well tolerated. I think the biggest side effect of these presentations or these reactions is just how they're given or administered in the body. And so they are given through a line, usually a central line. Sometimes it can be a peripheral line. Again, some patients don't tolerate the infusion super well. So we pre-medicate all of our patients typically with Tylenol, steroids, and sometimes Benadryl just to make sure that they're tolerating the medication while they're in the hospital well. And that is that slide. We can go to the next one. The other component of induction is the corticosteroid. So this is a very high dose corticosteroid. Most centers are using anywhere from like 250 to 500 milligrams. And so you can see very acute side effects from these high doses of steroid, but not to worry because you don't go home on these high doses of steroids. They usually taper down within the next couple of days after your transplant. But certainly we can see some immediate side effects, but again, you would be hospitalized during this portion of the immunosuppression administration. And so your team would be addressing these things on a daily basis. So definitely we can see impaired glucose intolerance. We can see higher blood pressure that's mediated by fluid retention. We can see movement of our white cells into the circulation of our body. And so sometimes we'll see elevations in the cell counts, but that we know is because of the medication and how it works. Sometimes this medication makes a patient super hungry, which also contributes to high sugars during the hospitalization. For some patients, it can cause a little bit of a mood disturbance if we give them high doses of steroids. And for some patients, it could impair wound healing, but I typically don't worry about this issue because, again, we are doing a lot of monitoring and we're also managing all of these things while you're inpatient and then reducing the dose day by day. Okay. So things to watch out for and things that your team is certainly going to be looking at while you're in the hospital is measuring your sugars, your blood pressure, making sure your electrolytes are normal, and checking daily weights to make sure you're not retaining extra fluid due to that medication. Next slide. And so this is just kind of a placeholder to say that, again, the point of all of that induction phase, that very strong phase, is to move over to the maintenance phase, which will be the lifelong phase. We can go on to our next slide. These are usually the medications that we're dealing with on a day-to-day basis. So you can see it's quite an arsenal, not super big, but these are kind of the classes of medications that we utilize. So again, calcineurin inhibitors and anti-metabolites, so things like tacrolimus, you might have heard that name before, cyclosporin, usually one or the other. We're probably never going to use both at the same time. And then the same thing with our anti-metabolites, so things like mycophenolate, sulfonylurea, or also azathioprine. And then the other groups of medications are the corticosteroid, the mTOR inhibitors, and the luspatercept. But those, I'd say, are not, the last two aren't utilized all the time. Next slide. So the important thing about all these classes of medication is that we want our patients to feel very comfortable taking them. So before you go home after your transplant surgery, you will definitely probably be meeting with a coordinator or a pharmacist, depending on your center specific processes. But you're going to have intense education about these medications because we want you to feel comfortable taking them and making sure that you know why they're important and how to manage any potential side effects. So this is a very busy slide, but again, I just wanted to introduce the fact that calcineurin inhibitors are usually the backbone of the regimen. They come in various different sizes, different types of formulations, but the important thing to know about this medication is that we check levels. So you'll see at the bottom of the slide that monitoring is an important component. And so we'll talk about that in a little bit. We'll go to the next slide. So this is some of the side effects that we can see with the medication. You'll notice that nephrotoxicity or toxicity to the kidney can actually be a side effect of these medications themselves. And that's mediated by ischemia or lack of blood flow and oxygen to that graft. And that's contributed also by having high blood pressure. So having good blood pressure management after transplant is something that's very important. And another reason why we check levels of the medications in our patient's blood. For some patients, these medications can cause neurotoxicities, so confusion, altered mental status, headaches, tremors, and we'll talk a little bit about managing that in a bit too. The medications can also cause direct toxicity to our pancreas, which is the part of our body that makes our insulin. So for some people, if they're pre-diabetic specifically or have a history of diabetes, it might make their diabetes worse after transplant. We kind of talked a little bit about the importance of blood pressure monitoring, and then some other random side effects. So tacro, for some people, can cause alopecia or hair loss, or hair thinning more specifically, whereas cyclosporin, the other option, can cause more intense hair growth. It can also lead to higher lipids in our body and issues with the gingival hyperplasia. Typically, we think that tacrolimus is a little bit more potent, and so most centers will be using tacrolimus as their starting calcineurin inhibitor. Next slide. This just shows why we check the levels of this medication. So this is a study that was done many, many years ago, but I really like this slide because it shows the importance of taking your medication and then following up with your team to make sure that we're getting good levels and that they're in range or within goal. And again, everyone's goal could be a little bit different, but this just shows that having a very high level, which is indicated by the white triangle, when you see that, you might see an increase in the creatinine that's mediated by the nephrotoxicity. So again, we want the level to be high enough to prevent rejection, but not too high that it's causing any unwanted side effects. And then the white circle at the bottom, that's just showing you that when you have a low level, you're putting yourself at risk of rejection. So again, we're looking for that sweet spot kind of between the figures, and that's kind of how we practice. Next slide. These again are the anti-metabolites that we use. We won't talk too much about these. These you take at the same time as your calcineurin inhibitor. Sometimes we can check levels of this medication, but it's not something that we use very frequently in clinical practice. Usually we're checking it if we're really concerned about a side effect, such as nausea, or if you're having a lot of stomach upset, it might be due to the medication, but typically this is not something we're doing every single day or every time we see you. We'll go to the next slide. So some of the side effects that we think about with these medications, they both have the potential to cause hematologic side effects, like leukopenias, anemias, and low platelets as well. And for some patients, specifically with the mycophenolate products, they can cause nausea, loose stools, or even dyspepsia. The most important thing is that you never just stop taking your medications. If for whatever reason you're having intolerances, that's when it's important to talk to your team so that we can come up with a better way for you to be able to tolerate the medications so they can do what they need to do without just stopping them. That's the most important thing that we tell our patients. We'd rather you call us or come to clinic and have a discussion with us so that we can find a good way for you to tolerate your medications, or if not, for us to explore some of those other medications that I'm not going to talk about today. Okay. Yes, and so this is the last slide. Like I said, the biggest thing is having a good relationship with your team and open lines of communication. I would say for the most part, these medications are pretty well tolerated, but if there is an intolerance, just again, reach out to your team. That's why they're there to help you. And that's it. I can answer any questions. I see one in the chat. One of the questions is, do you have ideas to counter the hair thinning that occurs through the meds? I think it's caused by the tacrolimus inversus, extended release. As a woman, this is becoming problematic. Certainly, this is something that we talk to patients about sometimes when I see it. We recommend like an over-the-counter biotin supplement, and also zinc can help. And there is some thought that taking the extended release formulation, so something like inversus, might help prevent that or delay the thinning. The next question was, how does the dose of the medication and the dose change based on how close of a match the kidney is? So I would say that that might not change the dosing, but certainly if it's, I wouldn't call it a poor match, but I would say if there's a concern about having any antibody towards your donated kidney, then that might be an instance where your team is thinking definitely a 3-drug regimen as opposed to a 2-drug regimen. But we'd have to see more specific information to see exactly how that could be managed.
Thank you so much, Dr. Sanchez.
Mm-hmm.
This has been very informative, and we appreciate you for spending Saturday afternoon to educate us. Every time I attend these programs, I learn something new, and you have taught me something new today too. So thank you.
Yeah, no problem.